If you don't know me, my name is Afreen. As Isha said, I'm a recent graduate. I graduated last year in the month of April, and a funny story about that actually. And I decided long before graduation that I was going to do my house job at a large public sector hospital, specifically at Lahore General. So this session is going to be entirely about that, about my experience, about the pros and cons of doing house job at a public sector hospital, and what you should be studying and covering during your holidays if you're from old final year and you just recently finished your finals and you have your days off and you're anticipating your house job, then towards the end, I'm going to be sharing with you guys specifically a curriculum that I developed based on my personal experience for house job. And the curriculum just covers all the topics that ideally you should be covering during your time before house job. Right. So moving on, let's just get to it. Okay, so you watch those productive videos on YouTube where they tell you the first thing you should do when you wake up in the morning is eat the frog, which is a metaphorical term for just do the hardest stuff on your checklist first so you can have the rest of the day for the relatively easier stuff. And that's what I decided how I would start my house job. First of all, I'll just put it out there. General is known for its surgery and surgical allied departments. They're really, really good. They have a high influx of patients. They train their residents really well. They train their interns really well. And if you are really interested in pursuing general surgery or neurosurgery or orthopedics or urology as a specialty, I would highly recommend that you gain some form of clinical exposure at general, even if not as a house officer, right? So basically at general surgery is divided into three units: surgical unit 1, 2, and 3, right? And each department works at a different pace, right? Now, surgical unit 1 was known for being the most notorious, making the residents and the interns go through long 24-hour shifts, starting at 6 a.m. and ending at 6 a.m., and then having to go to the OR for elective procedures and washing up for long ass procedures from 8 a.m. till 2 p.m., right? So you can imagine how much of a pain and how hectic those kinds of duties can be, right? So for example, in surgical unit 1, our schedule was like this: Mondays and Thursdays, we'd have grand rounds, uh, grand rounds in the wards where everyone from the head of the department to the house officer, everyone would attend those grand rounds, and we'd cover each case bed to bed, right? And in surgical unit 1, or in all of the surgical departments, as much as I heard, the house officer was recommended, encouraged even, to present the bed, even to the head of the department, right? So you'd present the bed, you'd present the history, the examination, if they had a procedure, what procedure did they have, and what was their post-op day, or if they were just recently admitted, what were they admitted for, recent investigations that were done, treatment, and what kind of medications are being given to them in the treatment chart, and what should be, in your point of view, the plan of action, right? So you'd present the bed to the head of the department, right? And then Tuesdays and Fridays, we'd cover 24-hour shifts at the ER. When I was working in surgical unit 1, our shift would start at 6 a.m. and they would end at 6 a.m. next Wednesday, the next day. we'd be working for 24 hours straight, whereas in other surgical departments it was like a 12-hour shift. So the house officers just worked from 6 a.m. to 6 p.m. and then they'd make a switcheroo, and then the new batch of house officers would work for the rest of the 12 hours, right? But it wasn't like that for us. And Wednesdays and Saturdays was elective procedures. We basically covered everything from a laparoscopic cholecystectomy down to a panproctocolectomy. So we had a wide range of procedures going on that we had to wash up for, and they would go on from 8 a.m. till 2 p.m. And yeah, you can imagine the state of your body and mind after you come home from a 36-hour shift where you've done God knows what, right? So our schedule was basically like that on a week-to-week basis. And now back to the topic at hand, it's that's okay, what have we learned in each of the things that we've done, right? So on Tuesdays and Fridays, we'd have ER shifts and on the one hand, and we'd have OPD on the other hand as well. So one batch would cover the ER shift, the other batch would cover OPD, which would go on from 8 a.m. till 2 p.m., right? And basically, we covered a wide variety of cases. Now, I personally learned the most at the ER, not just for general surgery, but for obstetrics and for medicine and for everything, basically, right? And the most important, the biggest, the most important thing we learned at the ER was managing a case of a road traffic accident, because those that know General was at Firozpur Road, and Firozpur Road is basically connected to Kasur, and it's a main road that connects the city to different cities in Punjab, right? So we'd get cases of RTAs all the time, really bad traffic accidents. And basically we learned how to manage them on the fly as soon as a stretcher would roll in. And we'd first learn we learned how to examine them, how to take their history, and how to perform relevant investigations if we had to refer them to ortho, if we had to refer them to neuro, because basically we have like a whole building for accident emergency, and at the ground floor we'd there was a hallway where we had general surgery covering trauma cases on one side, and we had neurosurgery on the other. And ortho was located on the third floor of the building, right? And right on the ground floor, on the opposite side, we had the minor operating theater where we performed minor procedures such as incision and drainage for abscess, or debridements, wound debridements, or dressing, all those kinds of things. And we had emergency surgery operating theaters located for general surgery for the trauma cases they had to cover, two reserved for orthopedics and spine, and two for obstetrics and gynecology. And anesthesia would cover all six of them collectively, right? So it was a pretty hefty ER shift, not just for us, but for everyone, basically. Neurosurgery didn't get any ORs in the emergency building because neurosurgery, as you may or may not know, has its own whole building. It's called PINS, Punjab Institute of Neurosciences. So whatever patients they admit through General Hospital's ER, they take them to PINS, and they manage them there according to whatever procedure or protocol they have, right? So apart from road traffic accidents, we cover We'd cover acute cholecystitis, we'd cover appendicitis, we'd cover compartment syndrome, we'd cover acute abdomen, and a lot of these severe cases. Basically, you'd have these wide variety of cases that you'd learn to manage over time by recognizing the pattern and whatnot. And yeah, this was the ER. On the OPD, the other hand, we I personally saw many, many cases of the thyroid, so like multinodular goiter, some cases of thyroid carcinoma, and and acute cholecystitis confirmed with the cholelithiasis, right? And we admit such patients accordingly for our elective list. And on the other hand, in the OPD, this was one on the one hand, you had general OPD, right? Where you had one room reserved for the vascular surgeon uh, who would check patients for DVT or dialysis patients for a fistula, stuff like that. You had a separate room reserved for the thyroid surgeon. We had a thyroid specialist that would check patients that would just check MNGK patients and decide if they needed to be admitted for a thyroidectomy or a lobectomy of sorts. We had a room reserved for carcinoma cases, colonic carcinoma, carcinoma head of the pancreas, right? And we had a procedure room where we'd perform the proctoscopy of the patient to check for hemorrhoids or any form of anal masses, right? And we had a room reserved for suturing of sorts, suturing minor wounds or taking out any previous stitches that that patients had, right? So you had a room for each and every single thing basically, and you got a nitty gritty of all of these rooms, right? On the other hand, you have the breast clinic, so that's like a whole separate area. I remember being sent down to the breast clinic several times to manage on my own. So in the breast clinic, I'd sit in one room where I'd take the patient's history, examine them, and manage them according to the triple assessment, right? And on the other room, the radiologist would sit and perform an ultrasound and take a biopsy if it was required, right? So a lot of the times you'd end up managing these patients on your own without the residents. Like Shurume, obviously the resident is there to help you, but over time, as you become more experienced, they let you handle things on your own, right? And yeah, so that's the ER, that's the OPD. In the ward, what we do is now we had 24-hour ward calls, right? So originally, acha, I don't know if this is like a tradition in any other hospital, but in general, especially when it comes to general surgery and even in ortho, you have something that we call a ward week, right? Now, in general surgery, the ward week lasts for 72 to 96 hours, right? But in ortho, it's like a full week. So you start your shift on Thursday and you end it on Wednesday, for example, right? So, so each batch of house officers had to do one ward week a month. Back when I was doing surgical unit one, right? And what you do during ward week in the 3 to 4 days that you're there consistently at the hospital, not going home at all, just living with the other fellow house officers and the residents, you'd basically take care of the patients. Okay, how do you take care of the patient? Now, in surgical unit one, since it was a very reputable department, we had the most number of beds. So there were like 35 beds for reserved for the male patients and 35 beds for the female patients. And Obviously, right after we'd have an ER and an OPD day, all those beds would fill up, and there'd be basically no space for any extras, right? And we had an HDU of 10 beds for male patients and an HDU of 10 beds for female patients each. And we had private rooms again for private rooms reserved for male patients and private rooms reserved for the female patients, right? So we had a lot of beds for patients, generally speaking, right? And what we do is on Mondays and Thursdays, we'd perform grand rounds, and our head of department would give us a plan of action for each and every single bed. And then the entire department would divide the beds amongst themselves, the residents and the house officers, and they'd manage the round orders accordingly, right? So, yeah, when you're on call, it's basically your job to keep the patients alive, right? And you'll be post-op patients and that have had their procedures done the day before. You have to do their dressings, right? So again, it depends on what procedure has been done, right? If it's a thyroidectomy case, Uski dressing is not so difficult. It's relatively easy. If it's a laparostomy case, well, I think the most interesting dressings I have done personally were laparostomy ke and uske alawa fasciotomy ke and below knee amputations of diabetic patients, right? So these three stand out the most to me because of because of the okay, so let me just describe it to you. So in a laparostomy, what you do is, okay, laparotomy may you open up the abdomen, okay, you explore the abdomen, you explore the gut, you explore the liver, you go through every single thing, right, to find out the cause of the patient's symptoms, right? And you manage accordingly, and then you close the abdomen. In a laparostomy, you don't close the abdomen, you keep it open and you cover it up with a vacuum bag and you stitch that back to the skin, right? Now, when a patient like that is admitted in the ward and you're on call, it's your job to wash the contents of that bag twice a day, right? Because it can be filled with pus, it can be filled with debris, all kinds of things, right? So it's your job to take up couple bottles of normal saline, a kidney tray, position the patient, and then wash the contents of the bag, right? You're basically washing their gut. So you do a laparostomy when the patient is a case of peritonitis and they have a lot of contaminated fluid in their peritoneal cavity. So you can't essentially close the abdomen in that case. Otherwise, you'd leave that fluid in the cavity to infect, right? So you just leave it open for everybody in the ward week to wash, right? And the other dressing and the dressing for fasciotomy was also very interesting to me. It's very, very painful, right? When you remove the dressing and you assess the surface and you see if you examine it, you see whether it's healing well or if it's infected, what you need to do, what kind of dressing you need to do next, right? And then you you take a picture of the fresh wound and then you dress it up again. And the whole process, it's very painful for the patient no matter how many local anesthetics you give them, right? And the third type of dressing that I found very interesting personally was for patients that had to have a below knee amputation for diabetic wounds and whatnot. And they were they were painful, they were sensitive to the skin, and they were foul smelling. But again, I personally think this is how you learn. You learn the hard part and you do it, and that's basically how you gain your clinical exposure, relevant clinical experience, right? So, yeah, you do that. And on the other hand, you had to manage sick patients in HDU, right? If a patient got really sick, you'd have to find a bed for them in the ICU. Now, General has in total four, 4 to 5 ICUs, right? And you'd be begging for a bed from each of the ICUs for the specific patient. And at times you find the bed, which is great for the patient. At times you don't, and the patient dies, and you have to take care of the nitty gritty, right? And in surgery, whenever a patient died, if they had an open wound, then you had to close it. If they had a colostomy or an ileostomy, you had to stitch it up. If they had a laparostomy, you had to stitch it up. You couldn't just give the dead body away to the attendants like that. You had to clean it up. You had to stitch it. If they had a CVP line inserted, a CVP catheter inserted, you had to remove that. If they had a Foley's, you had to remove that. You had to do all the nitty gritty before handing the body away to the attendants, right? So that was basically the big chunks of what you had to do as a house officer in your ward week, right? And apart from that, you had to take blood samples as well. In the other surgical departments, it was the nurse's job. In our surgical department, the house officers were expected to take all the blood samples, both venous and arterial. So we had to do those. We couldn't just skip on our jobs just because it wasn't required in the other departments, right? And yeah, that was basically what we did mostly during ward weeks. And the third is the operating room. So we'd have a wide array of elective procedures. An OR would be reserved just for the vascular surgeon for them to do their cases, right? An OR would be reserved for thyroid procedures only. We'd have one thyroid procedure a day, right? We'd have one Whipple procedure a day. We'd have one panproctocolectomy or some kind of a colectomy a day, right? We'd have at least 2, 3 mesh hernioplasties a day and the same number of laparoscopic cholecystectomies a day, right? So you'd have a wide array of procedures going on in all kinds of the OR, right? So you'd have 2 Whipples, for example, 2 Whipples a week, right? And you have to spend 12 weeks in the department. So that's like 24 Whipples, right? And our hospital can't even do one. So, yeah, you gain a wide array of clinical exposure. There's no doubt about it. And I did a little bit of everything, but my main focus was on mesh hernioplasties and appendectomies because I believe they were more on our level. Not to mention the fact that you'd get more. I got more chances to assist and even perform specific steps of the procedures on my own in mesh hernioplasties and appendectomies as opposed to big chunks of procedures like colectomies or lap chole or Whipple, right? So I targeted these relatively smaller, more frequent procedures as opposed to the big ones because I felt I learned more from them, right? So that is basically the overview for general surgery. And yeah, one more thing. You never get tired of the cases you get to see, especially in the ward. You get to see carcinoma head of the pancreas, you get to see breast cancer, you get to see colon cancer, you get cases of the thyroid and the gallbladder, obviously, but they're not as fun and interesting as the cancers. And our surgical department was very well known for managing like it was very well known for managing carcinoma cases very well. So we had a lot of those types of patients, apart from the trauma ones. Right. So that is basically the overview for general surgery. I did my 12 weeks rotation in surgical unit 1, It was my first rotation ever. It was the hardest one, and I don't think any other rotation can compete with that. Moving on to the next one, I did obstetrics and gynecology after. I did not want to do it. I was originally planning on pursuing ortho because all the rest, because I don't mean to brag, but all the residents in surgical unit one were like, you're really good at your job for a house officer, and you should definitely think about pursuing surgery, especially trauma, because because you're well oriented in it, and yada yada yada. I was like, okay, and I thought, okay, well, you'll find a lot more trauma cases in ortho, especially. So I really, really, really wanted to do ortho because, especially since we had a bunch of residents from ortho rotating in surgical unit one at the time, and they really pumped me up, right? And yeah, but my father, well, he's a doctor and he's in internal medicine, and my mother's a gynecologist. And my father sat down with me and he had a conversation with me. So he said, okay, I should pursue obstetrics because for a junior doctor in general, no department can make your skills and prepare you better for surgery in general, be it general surgery or ortho or whatever, than obstetrics. And being a woman, I should know the basics. And as much as I didn't like that conversation, he had a point and it made sense. And a few of my friends were already going into obstetrics. So I was like, heck yeah, okay, sure. I'll do obstetrics and see what I can do. I had gotten feedback about the obstetrics departments from the house officers that had already rotated from obstetrics, and they said, okay, you get the most hands-on clinical exposure in obstetrics. Like house officers, if they're trained well enough, they even perform the entire C-section, cesarean section, under the supervision of the resident or the senior registrar towards the end of their rotation. And I was like, heck yeah, I want to do that. And they said, okay, you do spontaneous vaginal deliveries, you manage them entirely on your own. I was like, heck yeah, I want to do that too. So I started my obstetrics rotation next, and the first day was very traumatizing to say the least. My first day at general surgery was also very traumatizing because I I was I was starting my very first rotation as a house officer at a very new department at a very new hospital where I didn't basically know anybody, right? And they decided it was a good idea for me to have my first 24-hour shift at the ER. So yeah, I thought that was going to be traumatizing as hell, but it turned out to be really fun and interesting. Gynae, on the other hand, was Gynae started the same way. I had a 12-hour shift at the ER, morning shift. Well, actually, it wasn't for 12 hours. It was just for 6 hours from 8 a.m. to 2 p.m. And I had that shift from with my friends. So we went to Gyneka Labor Room, which is at the ER building and the first floor of the ER building. So at the first floor, you have the Gyneka Labor Room on one hand, and on the other hand, you have the medical ER, right? And on the second floor, you have its two operating theaters, right? Gynae on the first day was very, very traumatizing to say the least. And I felt like कि हमें बस किसी ने पकड़ के अंदर फेंक दिया है literally, and we had no idea what we were doing, what we were supposed to do. And we didn't like the attitude of our seniors, and they were irritated by the fact कि सारे ही house officers जो उनको मिले थे, they were brand new and they had to be taught everything from scratch. And इनके जो old house officers थे, they had collectively left the department because they had collectively finished their rotation, right? So it was a very rough start, right? But over time, it, I want to say got better, but I think Gynae was personally one of the toughest rotations that I have had, right? And it speaks volumes because when you talk about schedule wise, gynae was not as tough as surgical unit one, definitely, or medicine even. But the mental torture, my God. And the residents and the interns were collectively, I'm not even kidding, tortured mentally by the senior registrars, the assistant professors, and whatnot. And the things people say about gynae, gay gynae, just makes you go crazy, drives you insane, and all that stuff. Unfortunately, well, based on my personal experience, they were true, but they had a lot of factors to it. But on the other hand, Gynae did end up training me in the best way possible, right? So in the first couple weeks or so, I was assisting with spontaneous vaginal deliveries. It was at the so the labor room is divided into the receiving stage, the active stage, and the second stage, and post-op patients and HDU, right? So we had like five sections of the labor room, right? And receive a patient. Once the patient would enter the active stage, they'd be moved accordingly, right? And once they'd go through the second stage, they'd be moved through the second stage, right, where they would deliver, right? On the other hand, we had several patients that needed an emergency C-section. So they were managed accordingly upstairs in the emergency OR, right? And then they were brought down to the post-op, right? And for really sick patients, especially eclampsia or postpartum hemorrhage or placental abruption, they were managed in the HDU, right? So this was basically the structure of the labor room. And in gynae, the schedule went like this. You'd have on Mondays and Thursdays, you'd have grand rounds in the wards, just like surgical unit one, right? So we had about like 40 beds in the obstetrics ward, and 40 beds in the gynecology ward, right? And you didn't have to attend your, you didn't have to attend your, you didn't have to attend the entire round. If you were stationed in obstetrics, you just had to attend the round for that and vice versa, right? So basically, it was like that. And we'd manage the patients accordingly. We'd follow the round orders and whatnot. And Tuesdays and Fridays, we'd have the ER and OPD, right? Now, here in obstetrics, we'd have 12-hour shifts in the ER, right? So you'd have your first shift go from 8 a.m. to 8 p.m. and the second shift go from 8 p.m. to 8 a.m., right? And only the house officers had the 12-hour shifts. The residents had to do the full 24-hour shifts, and they also had to wash up in elective procedures post call on Wednesdays and Saturdays, right? So on Wednesdays and Saturdays, we mostly covered C-sections that couldn't be done in the ER because of the high influx of patients. Once we got done with those, we do hysterectomies, vaginal hysterectomies, obstetrical hysterectomies, simple gynecological hysterectomies. We do DNC. We do copper T removal, major and minor procedures going on in the elective operating rooms and this at the same time. And we had like 6 operating rooms and a post-op just for just for the elective procedures in obstetrics, right? And I learned the most in the late in my time during my shifts at the ER, right? So in the first couple weeks, I assisted in spontaneous vaginal deliveries, and over time, as I got the hang of them, I was told to manage basic spontaneous vaginal deliveries on my own, right? So I started with a multi-gravida patients, and over time, I started taking over primary gravida patients, right? And I did minimum 3 to 4 spontaneous vaginal deliveries in every ER shift that I did. And I did a total of 26 shifts during my time in obstetrics. So I did about minimum over 100 spontaneous vaginal deliveries. I managed them on my own as a house officer, having my first real exposure with obstetrics, right? And on the other hand, I assisted in a lot of cesarean sections in the ER and in the elective procedures, and they are over. I've assisted in over 50, 60 of those, and I've performed 1 to 2 of those C-sections independently with the under the supervision of the resident and the senior registrar. So gynae, though giving you a lot of mental torture and being toxic in those ways, really does train you, and it really does teach you how to not be how to not treat your juniors, basically, right? So yeah, this was my personal experience with obstetrics, and yeah, yeah. So by, by the end of my rotation in obstetrics, I was really tired. I was really burned out. I just wanted to take a really chill rotation and take a break from everything. But again, my parents got into my head and they said, I need to get done with the hard part first and leave the easy part for later so I can study alongside. I was like, okay, again, you make a very valid point. So I decided to tackle with medicine. Now, when I first joined medicine, I was not looking forward to it because I thought medicine was going to be really boring. It wasn't exactly going to be my jam. I spent 6 months in surgery and trauma and managing obstetrical cases, and medicine wasn't going to be as stimulating compared to the 6 month compared to those first 6 months, right? But it turned out to be like the total opposite. So, for those of you that don't know, Professor Dr. Khurram Salim was our associate professor of medicine in our medical school. And last year, just before I was going to give my final prof exams, he had left our medical school to join general, and he is now currently the head of the department running medical unit 3, right? And most of the house officers, they go after medical unit 3 because it's the biggest unit out of all the three in general. It has its own it has the biggest ICU, it has the biggest HDU, and it has the biggest wards, and it's a huge department basically. So I I decided to speak to the professor. I introduced myself. We had a little chit chat, and he let me join his department, right? And what I did in medicine was I tackled with HDU and ICU mostly because now, it depends on your personal goals. For me, my personal goal is pursuing anesthesia as a specialty in the near future. So for me, ICU especially was really important. But obviously, I wasn't going to get ICU right away. Basically, how things ideally work, generally work in medical unit 3 is that you start in the ward, and if they like you, they'll promote you to HDU. And if you do a really good job with the HDU, they promote you to ICU, right? Now, some interns end up working in the ICU for 3 months straight. Some end up staying in the ward for 3 months straight. But I made sure that I got to spend at least a month in each of these places, right? And for me, H2 and ICU were more important because that's where most of the critical cases were. And that's where the really interesting, juicy rounds happen. Juicy in the sense that you got to learn a lot from one simple round in an HDU or an ICU. And medicine was really diverse. It was really interesting. It was not like obstetrics where you were just stuck with doing C sections all day or SBDs all day. And you got to see a lot of cases and you got to manage them in very differently. Even two similar cases were managed very differently, right? And the best time I had personally speaking was in ICU because you did POCUS, you point of care ultrasound. So you did ultrasound on the bedside, you performed the central venous catheter, you performed lumbar punctures, and yes, that you get to perform these things as a house officer. Okay, I've performed lumbar punctures a lot of time. I was even told to perform a lumbar puncture of a patient जो कोट लखपत jail से आया था because he was very aggressive and all sorts of those things. He was a case of meningitis, basically, but it was partly because of that he was so aggressive. And I was told okay, I had to do it because it was my bed and whatnot. So I did that, and I think that was my proudest moment. Okay, I managed to do a lumbar puncture of such an aggressive patient, right? So yeah, I did ABGs. I attempted central venous lines, and I performed ETTs, and we do bedside ultrasound just to find positive findings, right? And anytime, and sometimes urology would come over to perform a bedside percutaneous nephrostomy, and you'd get to assist them alongside. And sometimes surgery would come over to insert a chest tube, and you'd get to assist them alongside again. So, a lot of fun procedures in HDU and ICU that I personally got to do. And my time in medicine overall was really great. The thing is, with General Hospital specifically, it's a specialized hospital for for neurological cases. So we had a lot of cases of strokes and meningitis specifically. And over time, you learned how to manage those cases specifically. So yeah. And my most recent rotation is in radiology. It's a relatively new rotation. I joined the department on the 12th of March. And so far, it's been going great. I've been learning ultrasound. What radiology here mostly prioritizes is that you master ultrasound within these 3 months, right? Ultrasound KUB, ultrasound abdomen, ultrasound pelvis, and obstetrical ultrasound. I'm currently learning obstetrical ultrasound, and for these 2 weeks for the rest of this month. After that, my morning station will change to something else. And they very recently started teaching house officers the Doppler ultrasound as well, which is very surprising for us because the Doppler is advanced even for the residents. So yeah, so far I'm really enjoying radiology, and there's so much to learn, not just in this department, but in all of the departments that I've rotated in, personally speaking. So, to conclude, if you do care about your career on paperwork, choose ULTH. If you want your pay slip and if you want to save your marks, choose ULTH for the CIP policy, which only works in Punjab, need I mention, and not for all the hospitals in Punjab, right? But if you really do care about your career and you care about the long term aspect of your career, then I would suggest that you be brave and you at least try and make a move. So you'd know where you stand. So yeah, that's basically it from my side. Thank you very much. I'd be looking forward to all the questions.
We do have a question in the chat box. The question says that there's a point that if you're going to a new place, people there behave with you like a stranger. Whereas if you do a house job in your own parent institution, they own you and they kind of teach you in a better way. What would you like to comment on that? Is that true? Did you experience that?
Not necessarily, because when I came here, I didn't know anybody at first. So here's the funny story. When I first came to General, What I how I started off was there was a seminar that was going on that was scheduled in April the 29th, right? And it was at Pins, and everybody was going to attend it, from residents to final year GMED students and whatnot. And I was like, okay, this is a place for me to go ahead to go and make connections, right? I could meet the other students and see que आगे क्या होता है, you know. I just needed to try and see if that would lead me anywhere, right? And thank God I attended that seminar because I managed to meet a lot of new new people, old final year med students, they guided me extensively on how to apply for house job and whatnot. And then an assistant professor in one of the departments contacted me. I'm going to keep her anonymous for confidentiality reasons, but like she was basically a part of our med school as well. She left when I was starting fourth year in med school to join general, right? So basically she had been working in general for like 2 3 years, right? And she said, you need to meet me in my office. We'll talk about the house job thing in detail." I was like, oh my God, thank you so much. So I took out the time and met her, and she got me in touch with one of the residents that did their house job at General, that was a graduate of Amiruddin, right? And she guided me extensively and gave me the contact infos of the relevant people that I needed to approach and whatnot. And she contacted them on my behalf, right? And when it came down to joining Surgical Unit 1, uh, now, one very important thing I had to mention is Surgical Unit 1 is ruled by Professor Dr. Farooq Afzal, who is also the principal of Amiruddin Medical College, right? So he is like a big figure in the entire hospital. And one major benefit I got from doing Surgical Unit 1 was that anywhere I went to, every time I said I did my rotation from S1, they'd be impressed in gynae, in medicine, everywhere. They'd be instantly impressed, and they get me to learn things, and they get me involved and all that stuff, because everyone knew how notorious Surgical Unit 1 was, and how well they trained their house officers and residents, right? So anyways, the department doesn't take house officers very like it's kind of very nakharire in the sense when it comes to picking house officers, because they have their own graduates on the one hand that have to do their rotations there, right? And on the other hand, they have their unpaid house officers, right? So the professor, she was very kind enough to go with me to talk to the department herself, and she introduced me to them, and they asked me a few questions. They signed my letter, and they said, "Okay." And then she spoke to the registrar on my behalf, and then that's how I basically joined Surgical Unit 1, right? And when it came down to gynae, I joined gynae on my own. I like basically during S1, I had met and befriended a house officer who had done her rotation in Gynae Unit 2, and she was recommending that unit to me, learning wise. Though I told her, okay, I had made up my mind I was gonna do Gynae and stuff. So she introduced me to the house officer in charge, the resident who was the house officer in charge of the department. Every single department has a house officer in charge whose job is to like distribute and make rosters for the house officers, basically, right? And so I handed my letter of joining to the house office to the in charge, and she took it instantly because they needed house officers. And when it came to medical unit, and during my time in medical unit 2, I found out that one of the senior registrars was actually our alumnus. She graduated in 2016, I believe. So yeah, when it came to medical unit 3, Dr. Khurram was one of us, and very surprisingly, he managed to recognize me and we had a casual chit chat. And I don't remember him at all. Back when I was in med school, he was known to be very aggressive and fierce and whatnot. But he was really nice when I had come to chit chat to have a chit chat with him, right? So M3 May I approached the in charge and I showed him my professional license and he saw I was from UL and he was like, "Oh, you're Dr. Khurram's student?" I was like, "Yeah, I was. Yeah, I was. I for like a fourth year and final year." And so most of the house officers in Medical Unit 3, they joined the department without Dr. Khurram knowing, which is the funny part, because Dr. Khurram does not approve of the foreign graduates. He is strictly against them. He does not think that they have had the proper education. उनको लगता है वो बस पैसे ज़ाय करके इधर आए हैं, ठीक है? But when it came to me, he was very casual, chatting and asking me about ULTH, कि वहाँ क्या हो रहा है, and he was like, okay, you can join my department and whatnot. And when I came to ICU, he asked me, "Ki, Acha, are you learning things? How is your rotation going?" And he even said to the resident kid, "This house officer is very hardworking, and वो normally house officers को नहीं lift कराते हैं, even Amiruddin वालों को नहीं lift कराते हैं." But like he complimented me in front of the residents as well. And the radiology, man, when I came to radiology, I got to know very recently that the registrar is actually our alumnus as well. He's a graduate of 2016. So Gynae I actually met two people. One of them was like a new, like they had finished their rotation recently और वो gynae में आए थे अपनी FCPS Part 2 की तैयारी करने. So I told him I was a graduate of UL and he was like, "Damn." And he said, "I'm gonna mentor you personally." I was like, "Aw." And the SR said the same and I was like, "Aw." So every place you go to, you find your people. And when they know okay, you're from the same school, med school as them, they give you a little bit of that extra support that most of the other people don't get. And again, you're still doing far better than the foreign graduates. I can tell you that.
Thank you so much, Dr. Afreen. Just one last question and we will wrap it up. We are running short of time. The question is that when you're in the surgery room, does the responsibility and pressure get easier as you keep going, or is it something that's always there, but just divided between the team members since day one?
Well, when it came to surgery, the pressure did get easier time because you're used to it. As time passes by, you know the people. You've worked with them not just in the OR, but like in the wards, in the ER as well. You get to know them personally, right? And over time, you develop your own skill set, right? The shurume, you're like, "Oh my God, what am I supposed to do? How do you stitch this? How do you retract that?" But over time, you get an idea of what you're supposed to be doing. So and you also get an idea of the primary surgeon's nature. So if they're angry or they're gonna yell at you, you'll be like, "Oh yeah, this was expected." If they're calm and chill, you're just gonna be like, "Yeah, this is gonna be fun," right? Gynae was that one rotation just met with each subsequent ER I did. um मुझे अगले ER से डर लगना शुरू हो जाता था, like in my first ER where we're covering emergency surgeries and whatnot, I didn't know what to expect. I just knew it was gonna be hell, but I didn't know what kind of hell it would be. Over time, as I got more and more exposure to it, I was like, "Oh my God, ye bhi ho sakta hai, wo bhi ho sakta hai." And they started appearing more and more frightening over time. Like it came down to the point during my last few weeks in gynae, जब भी night ER होती थी, night ER से पहले मुझे panic attacks होते थे because I knew what I had to expect. But night ER again गुजर जाती थी because of the residents and the fellow house officers. But again, senior registrars थे और associates assistants थे, professors जो तंग करते थे, और वो सबको ही तंग करते थे.
Right. Thank you so much, Dr. Afreen, for such an extensive and clarifying talk on your experience as a public sector house job. Thank you so much, everyone, for joining as well. I know this was a really long talk, but I hope all your questions were answered and then you were able to learn something, and this might help you make a decision moving on. Thank you so much, and Allah Hafiz.